and that happens to be Streptococci. Okay, again, as I've been saying over and over again, I'll give you a impact slide, and they are there from your book mostly. And if you pay attention, the chances are that you will get a visual memory. So this is again a typical injury, as you can see. I would consider that as a punctured wound. So what you see over here is a punctured wound, and I'll also give you a case example for this particular one as well. But you see it's bleeding, it's oozing, and if you pay attention, that it's swelling. So the swelling is increasing. Again, keep in mind, skin, soft tissue, muscle, and bone. So that's what the tissue is. Over time, so you can see that it's really, really getting nasty. So you have all these edematous tissues over here, a lot of erythema, a lot of damage being done. There are many cases for you to study from your book, but I think Dr. Murray picked up this good case, and I like it, especially for Streptococci. This is a 40-year-old man who was scratched on his legs, just minor injury, scratched on the leg by a German Shepherd dog. And then you can see he had this little wound, he didn't pay attention to it. And next day what he sees is that he gets low-grade fever, chills, headache, and myalgia. So he was taken to the hospital, and they saw what you saw in that picture, punctured wound, fluid coming out of it. They ran a culture for it, and they knew that it's more of a systemic effect. They put him on intravenous antibiotics. Within 10 hours, the person gets confused, hypotensive, and then the condition of the wound changes. They do a very quick kind of opening of the wound. That's what they do in surgery. We call surgical debridement. So before we amputate, we want to try to save that particular organ. That's what it means. And we go very extensively. And you would not even know how things are done ASAP. And then again, at the same time, they notice abnormal liver function, renal failure, pulmonary failure, cardiac abnormality, and the patient dies within 3 days of admission. So you can see from here, and one bacteria, which is Streptococci, starts from scratch and take you all the way through within 3 days. So you have 3 days to treat it, do whatever you want to do. In this particular case, the most important thing that I'm going to talk about in terms of tissue injury is called necrotizing fasciitis. So this is the initial wound that you saw, and you thought there was nothing. When you open it up, and you start looking at different planes, those of you who know the anatomy of the lower part of the leg, there are 3 planes, anteriorly, laterally, and there are 3 sets of fascia there. So you open up one fascia, and you see infection. You open up the second lane, there's a fascia infection, and you open up the third lane, and there's an infection. So what do you need to do? Because you are running against time. So you basically cut it off. So you can see before they would amputate, they will just debride it. You want to see, and unfortunately, myself, this is one of the worst cases that we normally deal in surgical ward, where when I was a young house surgeon, I used to come in the morning, and you have to wash this wound. It was a part of the physician's job. But it is really tough. And sometimes they do heal as well. I can assure you that. But many a time, this is the last minute resort because we want to save the patient. I'm pretty sure patient is going to give a consent that he's prepared to lose his leg and not to lose his life. So we are fighting against the time, and we are fighting against a bacteria called Streptococci. Now, first slide as usual, it's a gram-positive bacteria. You can see from here. It comes in pairs and chains, is a facultative anaerobe, and it has a complex nutritional requirement. And again, when you get infected, so you have all this soft tissue over there, you have muscle there, and bacteria wants to grow and chew up your tissues. So, and then again, go after blood as well. It does ferment carbohydrates. If you were to compare, very common question asked, be prepared for that, and this is an exercise in the end as well. I would want you to compare the injury with Staphylococci versus Streptococci, and you will see the most important thing in this case is Streptococci are catalase negative, as compared to Staphylococci, which are catalase positive. If you do a gram staining, this is what they kind of look like a chain. That's why strepto means a chain. So Streptococci as compared to Staphylococci, which are a bunch of grapes. Since they are very pathogenic, so we want to classify them because traditionally we have used many different ways to classify them. Based upon immune response, based upon the antigen, based upon an antibody response. So Professor Lansfield, she was the one who was working originally. She basically classified them all the way from A to W. But the most important are groups A and B and D. And then some of the rare groups. You must have heard about strep throat. So strep throat basically is coming from that classification, which Professor Lansfield did quite a while ago. The other classification, remember when we talked of Staphylococci, I said beta hemolytic pattern of hemolysis. So you can basically classify them on the basis of how they go after your red blood cell. Now, if they form complete hemolysis, we call group A and B. Incomplete hemolysis, we call alpha hemolysis, that group D and S, especially S pneumoniae. If there is no hemolysis at all, we call gamma hemolysis, like group D. And this is again important. We'll show you that some of them are going to cause a lot of hemolysis. And then finally, we can also use biochemical or physiological properties to classify them. But we basically use the first two most of the time. The classical bacteria in Streptococci is Streptococcus pyogenes. Again, the loves pyo suggests pus. And this is a group A. And that's one strep throat. It causes strep throat. So that's the notorious one. They call it gas. Group A Streptococci. So that's what everybody is careful, especially when it comes to infect kids. Now, biology, virulence, and disease is a gram positive. Again, it is called A because it has an antigen A, because that classification was based upon the antigen. And then again, it has a tissue-specific protein, M protein. So these are some of the important things that you have to keep in mind and you will be asked. Now, the other question is, why is Streptococci that pathogenic that within 3 days, starting from a scratch from a dog, kills you? So the reason is because it carries virulence factors. This is virulent bacteria. And we divide them into three. Number one, they avoid phagocytosis. They don't want to be phagocytosed. And the reason is because they have a capsule. They have some proteins which are called M-like protein. They have C5a peptidase. And that again is going to chew up complement which will come to help them phagocytose. So bacteria has that. They adhere and invade cells, so they're going to be very sticky. You cannot easily remove them. And that particular property is coming from, again, M protein, very important, liponucleic acid, because it's a gram-positive bacteria, and F protein. So M and F protein are important for them to stick, because bacteria has to stick to something before it will go into the system, go into the cell. And then, of course, they also produce streptococcal toxin, and there is a list of that. And these are called pyrogenic exotoxin because they cause fever. Pyrogenic means causing fever. They are Streptolysin S, Streptolysin O, Streptokinases, and DNases. So these are 1, 2, 3, 4 important toxins that they release. Because in that particular case, where the person had an injury to the leg, so these toxins were released by bacteria and they went into the system and they pretty much messed up the whole system, heart, lung, liver, everything. Now, it's also called pyogenes. Pyo means pus. It is responsible for suppurative diseases. Again, it can be an acute, as you saw, strep throat. You see pus there. And then it can also cause streptococcal toxic shock syndrome. So it also will have a super antigen, like we have an antigen for staph. But remember, staph and strep are two different bacteria. And then again, they can have a chronic diseases, rheumatic fever, glomerulonephritis. where, as we discussed earlier as well, we discussed that as a part of hypersensitivity as well, that sometimes an antibody which is formed in response to Streptococci will recognize another epitope on your kidneys, on your heart, where they will think as foreign and will attach to that and cause a disease we call rheumatic disease. The example again is a post-streptococcal glomerulonephritis, post-streptococcal heart disease, so on and so forth. Okay, so that was an important in terms of hypersensitivity reactions. If you grow them on colony, we have two different strains. We have Streptococcus pyogenes, which is A. galactiae. This is group A, this is group B. The difference is the colonies are small and the zone of hemolysis is large, as compared to this one where colonies are large but small zone of hemolysis. So more hemolysis, more destructive they are. So where are they present? So they basically are there on our skin, and you can see again skin over here, mucous membrane, pretty much the same diagram, protective. So people can cough out. So if you have a strep throat, you basically are coughing out this bacteria, and then again they will stick to your epithelium of throat, and then either can go into the blood, like in this case, or you may have a injury, like for example, a injury on the skin where this bacteria will get into it. You have a cellulitis. That's what you saw in that patient. And then again, these toxins that you see over here, they also act locally, but they can also be absorbed. So you can see over here, they get absorbed. So they are typically Streptococci toxins, and they are also super antigen. This one is a strep super antigen as compared to the antigen that we have. They may also cause some of the lesions that you normally see, like staph, impetigo. So if they stick to your skin for a long time, and you can see they will cause that. So the upshot of that is that group A Streptococci can start from the throat and then go anywhere, right? But again, some of these bacteria, for a good reason, want to adhere to your throat, like some of the viruses. Like you have this kind of feeling, you know, I've got sore throat. So sore throat can be viral, can be bacterial. Okay, so you have to be very careful, especially in kids, because if it happens to be strep throat, it's serious. If you don't treat it, and if you let the immune system take care of it, the immune system will make antibodies. These antibodies will attach to the kidney and heart of that kid, and eventually when he or she grows up, it will show autoimmune kind of disease or hypersensitivity type of disease, post-streptococcal rheumatic disease. Now, our concern as microbiologists and pharmacists and physicians and so, we need to find out how to take care of this bacteria, how to devise drugs, how can we stop happening, how can we save the life of that person who just got bitten by a German Shepherd dog. So we have to go and look at the structure of that particularly Pathogenesis. So you can see this is a typical bacteria, and like any gram-positive bacteria, you will see that it has a peptidoglycan layer. That's yellow one over here, right? And then it has a cell membrane, pretty much you're familiar with that. And then it has an outer capsule. So it has a capsule over here, this purple color capsule, the thick capsule, because anything which is capsulated, remember it needs attachment of complement, because complement is an antiphagocytic. And this has a hyaluronic acid capsule, that's what you see. And many of the immune markers basically are passing through and through. So they, for example, you can see M protein and M-like proteins are right from the cell membrane all the way through. So they are hanging out outside looking for some attachment. Then there are F proteins, and they are some other important aspect, for example, some of these toxins. But remember the word I'm going to talk about today, exotoxin. This means exotoxins are secreted, exited, as compared to endotoxin, which is a part of this bacteria. Make sense? So you can see it's called secreted proteins. So all those pyrogenic exotoxin, Strep O, hyaluronidase, streptokinase, they basically are secreted out, and your body will make antibodies against them. And these are important diagnostic tests. And some of them, like C5a peptidase is here. We have streptolysin over here. Some of them are heat stable, and some are heat unstable. And then you have plasminogen binding sites. So you can see from here, structurally, this is pretty complex, right? And our challenge for coming up with a drug will target each one of them, because each one of them has a function, okay? Now, again, you see cell membrane over here, right? Then you have peptidoglycan. It's a peptidoglycan. And then there are these specific carbohydrates that Professor Lansfield was using, which gave this particular bacteria name, A, B, C, D, E, F, so on and so forth. So this is a particular carbohydrate that actually stands out and gives particular strain's name. Then we have those F proteins and M proteins. You can see from here, F proteins, they're like anchors. Now, keep in mind when I say pathogenesis, the question you have to ask yourself, what is it that causes this particular bacteria that a person sneezes in front of me on my face and I get it, and then it goes and attaches to my throat? What is their specific attachment to the throat? So if you pay attention over here, these are your epithelial cells of the throat, right? And remember, most of these cells are covered by fibrinogen. Yesterday I talked about fibrinogen binding protein. That was the basis for attachment of bacteria. So the very first step the bacteria would do is attach to that particular bacteria where it's going to cause problem too, attachment. So this attachment over here, you can see to epithelial cell is via F protein and M protein. Now the question you can ask is that, can we come up with a drug, or can we come up with a mechanism where we can stop that happening? So we have to have an anti-F protein or anti-M protein thing to stop that happening, because we know for sure that this is what the initial attachment takes place, as compared to staph yesterday, where I said that they have a fibrinogen binding protein. So you have to stop that. So if you're able to stop that, then you pretty much can protect yourself. Now, if you want to develop a drug, for example, you want to go and look at one particular aspect of it. For example, in this case, what you normally see is that this is a region of a protein. So if you look at this M protein, for example, it may have more than one serotype. So we're looking at different serotypes. Some of them are variables, some of them are conserved, and some of them are like in between. And they basically hang out of this bacteria, and we want to sequence the amino acid sequence over here because they are proteins, and we want to come and block that, right? Now, you can see from here, all four types, they have those epitopes that basically, if you remember the term I used, cross-reactivity. So this particular aspect of variable portion of Streptococci is presenting an epitopes that are similar to epitopes that we may have in kidneys and in heart valves. So if your immune system sees that, which bacteria is presenting, it will stimulate and form antibodies. Of course, these antibodies are useful to attach to these and block their attachment, but these antibodies will also cause rheumatic disease called post-streptococcal rheumatic disease. Now again, as I said, we want to stop this attachment to the cell membrane, and this is for real. And the previous figure was a cartoon, but you can see this is electron micrograph. And again, you can see basically both M protein and liponucleic acid are associated with the pili. So there's a pili over here. Pili are also there, like what do you call attachment things where they want to go and like hair-like. So more kind of hair-like thing they will attach. And then again, if you gargle or do whatever, they're not going to wash away because they're pretty much tight. Now, the second question you ask yourself is that, well, what it goes, does it cause a local damage? We're talking about the group A Streptococci. Again, you will pay attention over here. This is one of the toxins, which is Streptolysin O. And again, this particular toxin can either bind to some of the receptors presented over here, as you can see from here. And some of these toxins have the ability to poke hole into your cells. This is the toxicity of these exotoxins. They will go and poke a hole and penetrate. So you can see this has ability to attach to the receptor as well, and this will go into that. And once it goes over there into the cell, of course, neutrophils will come and they want to fight this off. They will resist phagocytosis because of many things. And then again, you can see from here that the difference basically that you see between the S. aureus to the localized group of Streptococci is that they spread diffusely. So as shown over here rightly, they have more capability to cause diffuse damage. The other important thing is that the differences between staph and strep is that strep comes up with an enzyme we call hyaluronidase. Hyaluronidase. And the other name of that is a spreading factor. Again, go back to the impact slide. You saw a puncture wound, and then over hours, it starts spreading out because of the toxin released by Streptococci, hyaluronidase, and this will go and causing damage and spread out the whole body. We call that as a spreading factor. And you can see from here, that is hyaluronidase. And that basically is also a resistance to phagocytosis as well. So you can see from here, is especially, it's not going to get phagocytosed. And then it will go in circulation, and in circulation, again, will go wherever the circulation takes it to, okay? And then, so you can see from here Streptolysin O, Streptokinase, C5a peptidase, and hyaluronidase. And then there are other factors, like we talked about, spreading factor, but there's another factor which we call factor H. Maybe it's not shown over here. That basically is also called a binding factor. That is factor that basically binds and causes gas, group A Streptococci, to escape phagocytosis by neutrophils. So if we were to summarize this, this is what I've discussed in the last couple of slides. It's called pathogenesis. How does Streptococci cause disease? That's what pathogenesis is. So just to summarize, you can see from here, they avoid opsonization and phagocytosis. They adhere to the surface of host cell. They invade the epithelial cell, and they produce different toxin and enzymes. So this is how they cause the damage. Now, if you were to go a little bit in detail, you will see especially how do they avoid opsonization. Again, they had a anti-complement enzyme, right? So that again will chew up enzyme. And then again, they have a hyaluronic acid capsule, which is poor immunogen. So this means most of the capsules, if you don't have a good complement, they would not be opsonized. Or sometimes we say that they have this M protein, and then they bind to serum B globulin, which is factor H, and it is called a regulatory protein, and this for the alternative complement pathway. So if you remember your complement system, all three complement systems are activated in a particular way. Some of them are antibody dependent, some are not antibody dependent, and they all converge on one common denominator. And that particular opsonin, C3b, basically goes and attaches to the bacteria. And if you remember, I'm pretty sure you remember complement, B's are opsonins and A's are anaphylatoxins. So this is like a rough idea for you to remember that. We are interested in finding out what these proteins are. And again, sometime we ask ourselves is that why is it that this bacteria causes a persistent infection? Why do we get recurrent strep throat? So this is a question. So the answer for that is, so in every slide there's a question. In this slide, the question you'll ask yourself, why is it that people get strep throat over and over again? The answer is because they have these two proteins, M protein and F protein, and they basically assist them to invade into deeper tissues. So they are attachment thing that will help them to invade the epithelial cells. If you look at the enzymes that it has got, we talk about streptococcal pyrogenic exotoxin. They originally were called erythrogenic toxin because they were produced. So this would suggest to you that strep will cause fever. Now, if you give Tylenol or Advil, that is not going to help because the fever is coming from toxins. So you have to do something for the toxins to alleviate the fever. And this particular toxin, again, like a differential diagnosis, another bacteria that I'll discuss later is called Corynebacterium diphtheria, right, causing whooping cough. So that toxin is pretty much familiar to the toxin that strep has, okay? Now, let's take toxin number 1, Streptolysin S. This is important for us to know that this is oxygen stable. This is non-immunogenic. What does it mean is that it's not going to have an antibody formation, so your immune system will not respond to it. But this is cell-bound hemolysin, as you saw in the original slide, and it can lyse erythrocyte, leukocyte, and platelets. So this is pretty much hemolytic. If you look at the second toxin, which is Streptolysin O, it is oxygen labile, and again, it has capability to lyse pretty much everything. But the good thing, or the bad thing, whichever way you want to take it, that this particular streptolysin toxin has antigenic ability, so it will produce a response, right? And this kind of a response that this particular toxin produces is pretty much related to other oxygen-labile toxin. The question usually asked from this slide is, if Streptolysin O is a oxygen-labile toxin, what other bacteria may have a similar kind of toxin? So if we come up with a drug against this particular Streptolysin O, can it be used for some other drugs? So yes, some other bacteria, Streptococcus pneumoniae, Clostridia tetani, Bacillus cereus, and this. So these are 5 different bacteria that you have to remember will have the same mechanism of pathogenesis. What do we normally do when a person, like, what is the basis of the strep throat test? So then they do the test. What they are looking for is they're looking for ASO antibodies. That's what they're looking for. So they are looking for ASO antibodies. So antibodies are readily formed, Streptolysin O. So Streptolysin O is called ASO antibodies. So if your body is making ASO antibodies, you got strep throat. Okay, so that's another important question of it. Since this bacteria causes a lot of breakdown of tissue, so we found out that it actually has a very specific enzyme which can lyse blood clots and fibrin and deposit and proceed to streptokinase. So it is something bad that the bacteria does. Can you think of something good that can come up from this particular pathogenic bacteria? I mean, just critical thinking. If you are thinking, or I mean, if you're not preparing for immunology exam tomorrow. Some of you, I'm pretty sure, are with me. Remember, this is how you do critical thinking. The critical thinking is, I just told you that this bacteria produces a toxin that lyses pretty much all the cells. Okay? Now, it lyses blood clots as well. And sometimes we ourselves need to lyse blood clot. The moment a person lands up with a chest pain in ER, you know what do they give immediately? Streptokinase. They give him this toxin right away because they don't want this person to have a blood clot. And where do we get this streptokinase from? Who makes it for us? This bacteria. Does that make sense? So this is how when you think of drug design, you think of all these things, and you can see over here that this is basically an enzyme that can lyse blood clot and facilitate that. It helps bacteria to lyse the clot and spread. So it's good for bacteria to cause infection, But it's good for us as well because we want the same action in a different perspective. And then again, as I said earlier, antibodies against these also are also used for marker of infection. So there are more than one test available. Anti-streptokinase antibodies are also useful. Some of the toxin will go after the DNA of the cell. So that's another important thing. They make these typical enzymes which are going to polymerize or depolymerize free DNA. And that actually they do in the pus. So these enzymes themselves are not cytolytic, but they can depolarize free DNA present in the pus. So it's also a pus-forming thing. And you can use all these things, the enzymes, for another therapeutic or interventional use. Component C5a is important. It can recruit, activate phagocytic cells. So they have a enzyme to break it. So what they do is that C5a peptidase disrupts this process by degrading C5a. And also remember, C5a is an N-aflatoxin. And then again, as I said earlier, spreading factor, hyaluronidase, and many other have been described, especially for group A. So group A is toxic. It has virulence. It has many different things. I'm pretty sure, did you already, there was a question yesterday that you are good in stats. So you got confirmation of it last night or not? Not yet? You're still waiting for the confirmation that? You got confirmed. So I can say now that since you know the stats, so let's look at the epidemiology of that. Because yesterday we were doubtful. The class was doubtful. But today they is confirmed that everybody knows their potential. Okay. So this bacteria sits in upper respiratory tract and skin surface, right? And we call it transient colonization. It can sit over there for a while. It's going to cause pharyngitis and soft tissue infection. It can spread for a person. This is what you need to know in epidemiology. How can I get it? How can I protect myself? How can I protect people? So respiratory droplets. So this would mean if you call the school and say, my child has, it seems to me he may have a strep throat. So what would they say? Bring him to the school? No, because you don't want it to spread. So it can also spread from fomites. And then these are the people at a higher risk. You can see children, younger children, and people who have soft tissue infection, streptococcal toxicity, and then patient who may have had a prior streptococcal pharyngitis because they will develop rheumatic fever. So rheumatic fever, again, is a post-streptococcal thing. Diagnosis, pretty much you will see is the same. All you have to pay, we have to do gram staining microscopy, and then we can do serological test. Serological test, basically, you can see from here, we are going to look for, if they are, this is a direct test. This is serological. So direct test basically is, again, some of the biochemical aspects that these bacteria have. I told you, if I'm in doubt, I don't know whether it's a staph or strep. So the difference will be that strep is catalase negative as compared to staph, which is catalase positive. So I can do that test. Then I can do positive PYR reaction, and then again, susceptibility to basic tracing. So these are the three important things that we normally do when we want to differentiate staph from strep, because we want to be very specific. This is serological test, ASO titer. So you can see from here that it is associated with streptococcal pharyngitis, and there are some other things available. So what will happen is that they will look at the titer means what is the level of antibody production in your body? Is it increasing or decreasing? So that will also show, where do you stand. For example, what we normally do is if a person of young age comes and he has or she has valvular heart disease, so we can take history and ask them that, did that particular person ever had a pharyngitis? And was the person told that it is group A pharyngitis? So that would pretty much know that this is rheumatic fever disease because of the cross-linking of that particular thing, okay? So rheumatic fever associated with streptococci and not staphylococci, okay? And then the most important, glomerulonephritis. And again, I told you the valvular heart disease as well. We talked about that. Now, how do you treat it? How do you prevent it? And how do you control it? Again, penicillin, because it's a gram-positive drug of choice. And what do we do for those people who carry it in their oral pharynx? Again, you can see if they are asymptomatic, there's nothing we can do about that. And again, the rule is that if you give too many antibiotics, they're going to disrupt normal flora, as we mentioned yesterday. And then again, if you want to go for these people, the most important thing that they would do if you go to dentists, they will always inquire for the history of rheumatic fever. They will make sure, because you have a valvular heart disease, the chances are. So they want to ask you, did you ever had a rheumatic fever? And because what will happen is that you can develop bacteremia, infection of the blood, and then can also lead to endocarditis. Because if you have endocarditis and you already have a valvular heart disease, that you are a risk factor for the dentist. So you have to make sure that you know that. If you have had a kidney infection, what they would do is, they will still do a dental procedure on you, but they will put you on prophylactic antibiotics. Just want to make sure that you don't get bacteremia. You don't get problem, because the chances are that your kidneys and your heart may be compromised. Now, some of the other strains of bacteria in group B Streptococci is Streptococcus A galactiae. These are some of the important things I've just highlighted here. They are beta hemolytic. They are resistant to bacitracin. This is how you differentiate between one from the other. And pregnancy, sometimes 10 to 30% women carry it, and they don't know it because it's asymptomatic. The problem that we have is that this particular bacteria, that's where the A galactia sounds like a milk, something to do with the milk, something to do with pregnancy, something to do with babies. So you can see it can be transmitted through the placenta or during the delivery. Again, the pathogenesis is that you can see pneumococcus, which is another Streptococcus pneumococci. So that's the pneumoniae, Streptococcus pneumoniae. It's called pneumococcus as well. So you can see group B, they again come over here, but since some of the bacteria like to go to lungs, that's why the cells of the lungs are called pneumocytes, alveolar cell. That's why the bacteria will call pneumococcus, and it's going to cause pneumonia. So that's again strep. And especially yesterday we talked in detail about the vaginal flora, we talked about the toxic syndrome, we talked about all those tampon and all that effect. But you can see from here, especially in the vaginal flora, if there happens to be that particular bacteria, especially group B Streptococci, you may get neonatal sepsis, so that can travel up through vagina into uterus and then involve the neonate, and then again will be a big problem because as I said earlier, 10 to 30% of the pregnant women carry that as a normal flora in their vaginal flora. So you can see that's where it's coming from. Then again, some of them can also be shed off. You can see you can take it in, like in your gastrointestinal tract. It goes out of anal canal because of the perineal region closer in female, anal canal, urethra, vagina. So the thing is that they can also pass from one orifice to another. And since this particular toxin, it goes into the blood, and from blood it's going to go into meninges. Most of us, I'm pretty sure, all of you, it's mandatory that we get vaccinated against pneumococci. And the reason is because of the pneumococcal meningitis. It's mandatory. So you can see this bacteria is not group A Streptococci, it's a group B Streptococci, but for some reason, once it goes into your blood, it has an affinity, attachment to your meninges, very common cause of pneumococcal meningitis. So that's again a question there that you need to ask yourself. Is a Streptococci, since it has a liking for lungs, we call it pneumococci, but actual name Streptococcus pneumoniae because of the ability to cause pneumonia, ability to cause neonatal sepsis, ability to cause pneumococcal meningitis. There are many tests, and this was a test you may have passed by CAMP. It was a test, immunological test. I don't want you to go in detail, but just remember the name, CAMP reaction. Very good test to differentiate group B Streptococci from group A Streptococci. And lastly, a few slides for the Streptococcus pneumoniae. This happened to be beta hemolytic Streptococci. And then again, as I said, we all need to be vaccinated against that because of it causing meningitis. And you know meningitis is pretty severe. If you look at the biology, they look like lancet shape. They are gram-positive. One differentiating feature that's very commonly asked, difference between Staphylococci, Streptococci is a chain, Pneumococci or Streptococcus pneumoniae has this ability to appear as diplococci. So they kind of come in pairs. So you'll see them 2, 2, 2 if you were to look at the sputum culture or sputum microscopy. They have a teichoic acid which has phosphocholine, C polysaccharide, and they have an autolytic enzyme amidase in cell wall. So what you may want to do is that you have to make your own chart and see all Staphylococci, Streptococci, and all different bacteria, and like pathogenic factor, and you'll see all of them are different. When I teach you, I'm going to teach you one bacteria, but when I'm going to ask you, I'm going to ask you all of them at the same time. So you have to be very particular. If I ask you that what is the autolytic enzyme, where is this autolytic enzyme amidase present? So then you really have to kind of cramp and memorize that it is in the cell wall of Streptococcus pneumoniae, right? So this is like a comparative analysis, and I'm pretty sure there are tons of charts available. And we had some students for the last 6-7 years making many of them. I have got tons of them, but I would rather want you to make your own because you may have a different learning cramming style. But these, if they are highlighted over here, there's a good reason for them to be there. How do they cause virulence problems? Again, they colonize oropharynx, and again we talked about the surface protein F and M. They spread into normally sterile tissues. So that's an anomaly, lungs are sterile. But they have the ability to go over there. That's why, because they have pneumolysin. So they have a toxin which is going to lyse lung cells. And they have IgA protease, because IgA is an antibody on the lining of mucous membrane. So they come to lyse that up. Once they go and infect, they want to get rid of IgA because IgA is protected. They stimulate local inflammatory response because of the teichoic acid, peptidoglycan, and pneumolysins. So they can also create a local response. So you will see a local infection and then spreading out from there. And then again, like any other capsulated bacteria, all capsulated bacteria will evade phagocytosis because phagocytosis need attachment of complement. It needs attachment of antibodies before they present them to phagocytic cells. So what are the diseases that you normally see from Streptococcus pneumoniae? Pneumonia, sinusitis, otitis media, meningitis, and bacteremia. So you can see pretty much very generalized diseases. If you look at the gram-positive staining, you can see from here, this is the Streptococci pyogenes, typical chain, and this is the Streptococci pneumoniae. It has a typical diplococci and a little bit of like lancet-shaped color. That's what they, I think maybe the next slide will show you better. So you can see from here, they come like pairs. You see that? So diplococci. So if you ask which of the following bacteria form diplococci, the answer is Streptococcus pneumoniae. They cause pneumonia. I'm going to show you some of the clinical pictures, pneumonia over here. And they cause many different things. There is one historical incident with that. It used to be called scarlet fever. So there was scarlet fever, romantic historical microbiology aspect where people will have all these kind of spots on their body, on the tongue, and these kind of spots, they will call scarlet fever. And that's again very important. And they can also cause infections that you saw in staph, impetigo. But some of the infections are very severe because remember yesterday we discussed antibiotic uses alone is not enough, because you have to make sure that they don't cause a local damage. So if they cause local damage, like for example in this case, you can see erysipelas. This is a Streptococcus erysipelas, and you can see erythema, redness, you can see swelling of the face. And this is a typical group A streptococcal cellulitis. Whatever you're seeing on the face, actually what would have happened on your throat because of the tissue damage. So you don't see that, but you get pain. So that's what the strep throat is serious, especially for the babies. So you can see from here very, very severe and angry looking reaction. Your favorite slide, epidemiology. You can see the infections are spread from colonized nasopharynx and oropharynx. People will kind of sneeze, people will pass it off, you talk to people and they're going to pass it off to you. Colonization is highest in young children, and then again, sometimes you may have a viral respiratory disease, and then again, that will lower your immunity and you may have a secondary superadded infection. The problem again, children and elderly are at a greater risk for meningitis, and we have to then make sure that we use a vaccine. People who have other hematological disorder may also get problem. Ubiquitous means present everywhere. So it is present around the year everywhere, but it's more common in cooler months. Gram staining, typical one, so we have to use gram staining. One important thing in this particular bacteria, usually a very good question, is that since it has a very rigid capsule, what we do is that we take this bacteria and add polyvalent anticapsular antibodies and mix it with it, and then look for the swelling. So it kind of swells up. This is called Coulomb reaction. Coulomb reaction, very common test done to make sure that you're looking at that particular bacteria. You can also look at antigen tests for pneumococcal C polysaccharide, especially if you find a person who has meningitis. And this again is the outer wall polysaccharide C. And then again, you can culture, look for their ability to be catalase negative. They have susceptibility to optokin, and they are solubility in bile. So if this means bile is usually should be antibacterial, but this can survive, so it can also cause infection in gallbladder. Treatment of choice, again, for all gram positive. Now you know the danger. Yesterday we will mention about the MRSA. So if you have a methicillin resistant Staph aureus, if all these bacteria are causing so many problems, if your penicillin is not working, you have penicillin resistance, so we are in big trouble. But we do have a choice, fluoroquinolone, vancomycin, and it can be combined with many different things depending upon if people are allergic to that. And for prevention, the best thing is immunization with 7-valent conjugated vaccine for children younger than 2 years of age, and then 23-valent polysaccharide vaccine is recommended for adults. So what is the difference between 7-valent and 23-valent polysaccharide vaccine? What do you think is happening here? And why is it that younger children are given 7 and the older are given 23? Immunology question. So let's see how well prepared you are for tomorrow's test. Anyone? So these valencies basically are the antigens. So this means if they took 7 different antigens from this bacteria and made a vaccine against 7 different, epitopes, right? And you don't want younger children to be stressed out with more immune response. So you will give a 23 one, which more robust, a better as compared to what you are doing is you are giving your immune system 7 different IDs of bacteria. And say, hey guys, this is what this bacteria looks like. Children are okay because they can deal with 7. But adults, basically, they have 23 valencies, so it's very strong. So you're going to them 23 different IDs, and then it also will give you an idea that this bacteria has different IDs. Because there are humongous number of virulence factors, humongous number of the immune responses that you get. So the higher the number of valency, the more potent will be the vaccine and more potent will be the response. And finally, for your own exercise, I would recommend to you that you can start making some kind of comparison between group A and group B, because it's very common question asked within Streptococci. Within Streptococci. And then again, within two major bacteria that I've discussed so far, staph and strep, you should be aware and you should know what are the differences between staph and strep, because these are the two commonest bacteria that you're going to see everywhere. And this is the commonest bacteria that we use penicillin for. Okay? All right, thank you.